Rakesh sir, and welcome Dr. Devan. Over to you, sir. Devan, over to you, sir.
Okay, now?
Yes, sir.
Okay. Thank you very much, and it's a privilege to be here, and it's nice to have Devang with me to support me all through this long case, and young lady, Swati, there to present the case for today. So let us begin, I think. Swati, are you ready? Swati, unmute.
Yes, sir.
Okay, so let us begin with the case presentation, and then we will go as we go along. We'll keep on discussing.
Yes.
Please. Thank you, Bharti, for getting my name right, Rakesh Kumar. Though I am Sharma, but I don't write.
Good afternoon, everyone. My patient is a 60-year-old male patient, a smoker, Hindu by religion, rickshaw puller by occupation, residing at Faridabad, came with the chief complaints of cough with expectoration for 2 years, hemoptysis for 5 months, breathlessness for 3 months, weight loss since 3 months. The patient was apparently well 2 years back when he developed cough, which was gradual in onset, progressive in nature, with a frequency of 8 to 10 episodes per day, had no aggravating or relieving factors. The cough was associated with expectoration, which was initially white in color, serious in nature, thin in consistency, not foul smelling, copious in amount, as described by the patient, and has turned blood tinged for the past 5 months. There was no diurnal, postural, and seasonal variation. And there is no history of ingestion of drugs, fever, chills, rigor, and wheezing. Patient also complained of hemoptysis, which was insidious in onset, associated with the cough episodes since past 5 months. It was 5 to 10 ml per episode initially and has gradually increased to 10 to 20 ml per episode. It was bright red in color and frothy in nature, frothy from admixture of air. There was no history of nausea, vomiting, black tarry stools, no history of epistaxis, bleeding gums, no history of fever, no history of antiplatelet or anticoagulant ingestion. My patient also complained of breathlessness since 3 months, which was gradual in onset, progressive in nature, and was associated with the episodes of cough. And there was no history of nocturnal awakening to breathlessness or breathlessness on lying down. My patient experienced loss of weight. He complained of loss of weight of around 8 kgs, which was associated with loss of appetite. There was no history of chest pain, palpitation, syncope, no history of evening rise of temperature, no history of fever with chills and rigor, no history of hoarseness of voice and difficulty in swallowing, no history of contact with tuberculosis patients, no history of bone pain, muscle pain. Past history. He is not a known case of diabetes, hypertension, bronchial asthma, tuberculosis, epilepsy, and thyroid disorder. There's no history of previous surgeries, previous anesthesia exposure, hospital admission, and drug allergies. There's no history of any blood transfusion, no history of any COVID infection. Personal history. Patient is a known smoker for 30 years, smokes 18 to 20 cigarettes per day for 30 years, making a pack year of 30 and a smoking index of 600. Not a known alcoholic, vegetarian by diet, normal sleep habits, and normal bowel and bladder habits. Treatment history. The patient is on salbutamol inhaler for 3 months, taking 2 puffs BD, and ipratropium bromide inhaler for 3 months, taking 2 puffs BD for 3 months. Family history. There's no significant family history, and he's working as a rickshaw puller for 35 years. Summary: positive findings are elderly patient with a history of smoking, cough and expectoration since 5 months, since 2 years, hemoptysis for 5 months, loss of appetite and weight for 3 months, and breathlessness for 3 months.
And on the right are the negative findings that you have elaborated on, right, Swati?
Yes.
So, what do you think on the basis of this? What do you make out of the diagnosis be? Tentative
Sir, my differential, sorry.
Yeah, differential diagnoses.
Sir, it could be pulmonary tuberculosis or malignancy or consolidation, or it could be bronchiectasis, sir.
So what goes in favor of tuberculosis and cancer?
Sir, because my patient complains of cough and expectoration since 2 years. There is history of hemoptysis. There is history of weight loss.
So the most common finding, because hemoptysis and cough can be there in all other made. What
And
makes
also
it more towards tuberculosis or cancer?
Sir,
What makes this first diagnosis as tuberculosis or cancer? What in the history guides you to that direction?
Sir, history of smoking.
Smoking, of course, is there for everything. What specific thing in the history tries to tell you that probably we are dealing with a malignancy or a tuberculosis? What happened to his weight?
Sir, weight loss. There's a history of weight loss.
Happened to his appetite? Went down?
Appetite is decreased.
So both the things, isn't it?
Yes, sir.
Now, you said that he had dyspnea. Now, at the moment, he is having breathlessness, right?
Yes, sir.
What kind of, when you elaborated breathlessness, he can do his normal chores or not?
Yes, sir, he can do. He complains of breathlessness, which is associated with cough.
So now, is he still pulling rickshaw? Is he doing
Yes,
his
sir, the strenuous exercise is decreased, sir.
what is he doing his rickshaw pulling or not?
No, sir.
When did he stop?
Sir, since 3
What
months.
is missing in your history? I would have loved to know that for the past 5 days, 10 days, 15 days, he has stopped pulling his rickshaw. So that will tell me that his exercise tolerance is going further down, right? And you said that his smoking is one important part. Do you think that any relationship with the where he stays, his place of living? You know, where does he come from?
Faridabad.
So it is all NCR. We are all
Pollution.
smoking a lot of cigarette every day, isn't it? So
Yes.
these are some of the pointers which are there in this patient. So, and what kind of housing is he living in? Is he living in a closed place where 4 or 5, 10 people are staying? That could also, all these things, a little bit of things will add up to your history. Now you said he doesn't have any breathlessness on lying down, isn't it?
Yes, sir.
So then what is the point of asking that he is having nocturnal, he wakes up with breathlessness or not? When he is not having any breathlessness on lying down, that finishes that part, isn't it? So you don't have to say any further on that. Now, you also said that there is no history of fever, right?
Yes.
But then you don't have to mention anything about evening rise of temperature. Once you have said that there has been no fever in the past all these months, then that becomes superfluous. Now, he's taking salbutamol and ipratropium. Do you think he needed this? He needs this?
Yes, sir. Since because of the breathlessness, for that.
Every breathlessness person needs salbutamol and ipratropium. What group of drug is salbutamol?
Beta 2 agonist, sir.
Agonist, right? So, and ipratropium?
Sir, M2 receptor antagonist, sir.
Right.
Anticholinergics.
So both of them are causing bronchodilation, isn't it?
Yes, sir.
So does he need bronchodilation? From the history, you said there was no history at all of V's, ever. Huh? How do you take history that you have a V's or not? If you want to ask me, you want to clarify whether I have V's or not, what will you ask me? You know, I'm your patient, let us say. Ask.
जब सांस छोड़ते हैं तो क्या आपको कोई साउंड आती है क्या?
तो मतलब सांस लेने या छोड़ने
लेने
में
में
सीटी की तरह
कोई
या कोई आवाज तो नहीं आती, isn't it? So you had checked it and he doesn't have any of these, right? So that is another one. So these are the important part that we have discussed in the history, and on the basis of that we have a framework of this kind of diagnosis, right? Let us go on to the examination now. General examination. Dr. Devang, you want to chip in? Okay. Carry on, Swati. Share your screen once again and let us go further.
remove this.
Okay.
After taking the consent from the patient, I examined the patient. The patient was conscious, well-oriented to time, place, and person, average in build, with a weight of 50 kgs and height of 162 centimeter, making a BMI of 19. The patient was hydrated, with the peripheral veins accessible. Pallor was present. The clubbing was present and was grade 2. Lymphadenopathy was absent. There was no cyanosis, icterus, and pedal edema. Hemodynamic parameters. The pulse was palpated in the right radial artery and it was 70 per minute. Regular in rhythm, normal volume and character. There was no radial and no radiofemoral delay. The condition of the arterial wall was normal. There was no thickening found. The respiratory rate was 22 per minute and the breathing type was abdominothoracic. There was no chest retractions, no use of accessory respiratory muscles. Blood pressure was 126 by 72 mmHg, measured in the right arm in the sitting posture with adequate cuff size, with the level corresponding to heart. Patient was afebrile, JVP was not elevated, and there was no engorgement of the veins over face and neck. Airway examination. There was no obvious deformity of the face, neck, nose, eyes, mandible, and ears. Both the nostrils were normal and patent. Oral hygiene was good. There was no artificial tooth, no buck tooth, no loose tooth found. Mouth opening was more than 5 centimeters. Thyromental distance was more than 6.5 centimeters. Hyomental distance was more than 6 centimeters. Sternomental distance was more than 12.5 centimeters. Neck extension was adequate and temporomandibular joint mobility was adequate. Modified Mallampati grading was 1.
Can we stop here? Just a second. Previous slide, please. पिछली slide पे जहाँ. So please, everybody. नहीं, इसके next. हाँ. Or next. और next बेटे पीछे नहीं, आगे. Next. हाँ. So Malampati is the name of a person. So M should be capital. And it doesn't have 2 T's, it has only 1 T, right? So please remember that. And it is not grading, it is class. Usually it is put as class. While the Cormac and Lehane is grading, Malampati is a class. Usually that is the way it is written. So rest of the things are fine. And so the person is 50 kg and 162 centimeter, right? Chalo, aage chale. Bedside PFTs.
Bedside pulmonary function test. Breath holding time was 19 seconds. Single breath count was 25. Forced expiratory time was 5 seconds. Snitter match blowing test was done and the patient was able to blow the candle at 3 inches. Cough test was positive and the wheeze test was negative.
What does it
Stomach.
mean? What does this bedside test mean? What do they mean? What are they telling you?
Sir, they are telling because the Sabris's breath holding time tells the cardiopulmonary reserve of the patient. Now, because it is decreased, it shows that the cardiopulmonary reserve has been decreased for the patient. And the single breath count test, sir, more than 40 is considered to be normal. Now, my patient has it 25, so it is decreased. So the vital capacity of the patient is decreased. And Snyder match flow test for this maximum breathing capacity. It tells about the maximum breathing capacity of the patient. Depending upon the distance, it is the patient is able to blow the candle. At 9 inches, it is considered. It is more than 150 liters per minute, and for 6 inches, it is more than 100 liters per minute.
How did you do this test?
Sir, I performed it by asking the patient to open his mouth and while take a deep breath and then blow the candle, which was placed at 9 inches, then 6 inches and 3 inches. And I asked him not to purse his lips while blowing the candle. And I made sure that the fan was off and there was no external air around.
So, please look at me. Did he do like this?
Yes, sir.
I'll do it again.
No, not by moving, sir. He was staying there only.
Why will he stay there? This is a normal reflex. You do it, you will also do the same. If I want to blow a match, my normal tendency will be, this is the way we do. Try it. This is the way you will do. So how did you ensure that he did not?
Because I instructed him to not to move.
That is very natural, so natural a reflex that very difficult. So you need to support the chin here while he does it. So you have to ensure that the head doesn't move, right? If you have to do these bedside tests, although the kind of history that we have, because he is undergoing, he is slated for pneumonectomy/lobectomy. Yes, these tests are important and well done. Carry on. Go on. Let's go further. So, यहाँ पे एक दो सवाल और पूछ लेते हैं. How many bronchopulmonary segments do we have?
Sir, 9 are bronchopulmonary segments. 9 are there on the left side of the lung, and the right side has 10, sir.
So there are 19 bronchopulmonary segments, you mean to say?
Yes, sir.
I thought there were less of them. So there are 10 on the right side. Yes. So on the left side, there are 9. And which one is missing?
Sir, what?
Which one is missing on the left side?
Sir, one basal, sir. One in the basal.
Which basal? Because it will accommodate the heart. No? So one basal will be missing. Which side? Medial, lateral, anterior, posterior, or superior of the lower? Just guess where the heart is.
Lateral.
Heart is lateral.
The medial basal.
The lungs, lungs envelop the heart, isn't it? So it will be on the medial side, right? What is the normal tracheal diameter in an adult male expected? Okay. What is the surface landmark of carina? Surface landmark in a patient?
For a?
Carina, tracheal carina. Where does the trachea divide? Surface landmark for that. On the surface.
Sternal notch, sir.
Sternal notch here. So this is the sternal notch. This is where the trachea divides. Okay. Spine ke hisab se, dorsal-lumbar spine, at which spine level trachea divides. These are very important to intensivist and anesthetist because we are going to choose a tube's length on the basis of that. So no superfluous questions, please, isn't it? So similarly, I have to decide the tube size as far as the diameter is concerned, right? So all these are relevant to your case. So please remember that the trachea divides at the angle of Louis, right? Manubrium and the body of sternum where they join anteriorly, and the lower margin of T4 posteriorly, if you are looking at an X-ray, right? And this part is the mid trachea, actually, the sternal notch, what you said. Okay? Right? Swati, are you
Yes, sir.
listening? So,
Yes.
what do you understand by FVC? Can you define it?
Sir, forced vital capacity.
And what is vital capacity? Can you define vital capacity for me?
Sir, vital capacity is when the patient is asked to, sir, capacity is a sum of the volumes. It is the sum of the tidal volume.
That is a mathematical value. Give me the definition. Like if I tell you tidal volume, it is the amount of air I breathe in or out normally in every resting breath. This is tidal volume. I have defined it, You asked me, so similarly, vital capacity, what is it?
Sir, when a patient, after taking a deep inspiration, expires forcefully and maximally, that is known as the vital capacity.
So the amount of air that the person pushes out after a maximum inspiration forcefully is forced vital capacity.
Yes.
You have defined it now suddenly, So don't think about those pluses and minuses, Don't add the volumes to make a capacity. They do make, but then you should know exactly what they mean. That is when we start thinking about FVC and FEV1. Out of that, what we breathe out in the first second will be FEV1. So please make up in your mind what these things are, right? Then you start enjoying that even more, right? So these are some of the basic questions I wanted to ask with this this particular topic. Chalo aage chale. Now let us go to systemic examination.
Systemic examination, respiratory system. On inspection, the shape of the chest appeared normal. There was decreased chest movement on the right side. The trachea appeared in the midline. The shoulders were symmetrical. Chest wall appeared normal. There was no intercostal retraction or flattening or bulging seen. There was no dilated vein, pulsation, scar, or skin appendages seen. On palpation, the trachea was shifted towards the right. There was no tenderness over the chest. Chest expansion was reduced on the right side. Chest wall dimensions were AP diameter was 22 centimeter and the tracheal diameter was 29 centimeter. Transverse diameter was 29 centimeter. Vocal parameters were increased in the right side when compared to the left side. Percussion. Normal resonant note in the left lung and right upper lung field were felt, and dull resonant note in the dull note was felt in the right middle and the lower lung fields. On auscultation, there was reduced air entry on the right middle and the lower lung field, and there were no added sounds. Cardiovascular system. On inspection, a apical impulse was not seen.
Nothing positive in this, isn't it?
No, sir.
Go on to the next one. Right, nicely done. Okay, this one.
There's no positive findings here.
The only thing I want to tell you is umbilicus has an I also. UMBILICUS, right? Umbilicus. Carry on.
Abdominal examination. On inspection.
There is nothing here, isn't it?
No, sir.
Right, very nice. Go on, next one.
CNS examination. There was no focal neurological deficit. Higher mental functions were normal. Cranial nerve motor sensory function were normal, and the spine was normal in curvature with no deformities.
Right.
Summary. 60-year-old male patient presented with a history of cough with serous expectoration for 2 years, hemoptysis for 5 months, breathlessness, progressive loss of appetite and weight for 3 months. The patient is a known smoker for 30 years and works as a rickshaw puller. The patient was found to have dull resonant and decreased air entry over the right, middle, and the lower lung fields, and increased vocal parameters on the right side of the chest compared to left.
So diagnoses?
So my probable diagnosis is malignancy or consolidation or pulmonary tuberculosis of the lung involving the right middle and the lower zone.
Okay. So I think, again, I like to put the consolidation as the third diagnosis for the simple reason that the history is long and there has been no fever as such and there has been weight loss, isn't it? So you'll not have a person having consolidation for so many years, no? Looks like that. Do you agree?
Yes, sir.
Okay. So we have this patient with you and you have done this history taking and examination. And you said that the right middle and lower lobe are involved, right?
Yes.
Looks like that. And because the surgeons find out that it is a cancer that they are dealing with, and it seems to have also abutted on the upper lobe, right? So on the right side, how many can you name the bronchopulmonary segments of the right side? 10 of them were there.
Sir, apical, anterior and posterior in the upper lobe. Sir, medial and lateral in the middle lobe. Then anterior, posterior, medial, lateral, and superior basal in the lower lobe.
Great. So they find that it is abutting even on the upper lobe and they want to do a pneumonectomy. So let us first discuss that they want to do a normal thoracotomy and a pneumonectomy rather than VATS. You know the full form of VATS, don't you?
Yes, sir.
What is that?
Video assisted thoracoscopic surgery.
Okay. So let us first talk about a regular surgery, and they have sent the patient to you, right? So you have done all this examination. Now, what do you want to order as investigations in this patient? 60-year-old, 50 kg, 162 centimeter patient.
Sir, after taking the complete history and doing the examination, sir, I would go for investigations. I'll order a hemogram, total leukocyte count, differential leukocyte count, platelet count, blood sugars, liver function tests, then urea and creatinine. Then I'll go for chest X-ray.
For a 60-year-old person, all these are normal, isn't it? We do it even for any surgery they come, isn't it? Whatever you said to me, hemogram, sugar, KFTs, LFTs, isn't it? And X-ray chest, and even an ECG. No?
Sir.
That we do for every 60-year-old person. Am I right?
Yes, sir, I would.
Setups, we do all this.
Yes, sir.
Anything other than this?
Sir,
Pneumonictomy. Yeah.
Sir, I will go for sputum testing,
Okay.
AFB, and I'll go for culture,
It
sir.
has been diagnosed. No, I told you it has been diagnosed as CA now. And it is abutting on right upper lobe also. So they want to do a pneumonectomy for CA of lung.
Sir, I'll go for spirometry, ABG, CT chest.
CB chest, what is that?
So CT chest, sir.
CT chest. Why do you need a CT chest as an anesthetist?
Sir, to see if the tracheobronchial tree involvement, the diameter of the trachea, and to see if there are any blebs or bullae.
Can we make out the tracheal and bronchial dimensions from a digital X-ray, which we do nowadays?
Yes, sir.
So if that is so, then I don't need a CT.
Sir, metastasis.
Of course, the surgeons will get it done for their sake, and we can always use that. But as an anesthetist, what should I ask for? Why do I need whatever I'm asking for, right? So you want to look at metastasis?
Yes, sir, metastasis.
Where do you
The
expect
where the trachea also, sir. I want to see if it is being compressed or it is being involved by the.
This is excellent modality. We do that only for thyroid cases, whether it is compressed, whether it is bent or whatever. No? Anyway. Okay, carry on. What else? So CT chest, X-ray chest, anything? No?
Spirometry, ABG.
Okay. Why do you want to do an ABG pre-operative?
Sir, I want to know the baseline PaO2 and PaCO2 values.
What will that help me in?
Sir, if the PaO2 is less than 60 and if the PaCO2 is more than 45 mg, then that will put the patient in a higher risk.
So what do we call this to find out how much is the risk of this procedure is called risk stratification. Risk stratification, isn't it? We are trying to figure out and tell the patient's relatives and surgeon how much risk is there when I take up this patient, right? Am I right?
Yes, sir.
What else do we do to risk stratify? Does anything out of your spirometry help?
Sir, we'll be assessing the meds of the patient.
Meds, spirometry में नहीं मिलते बच्चे. I said spirometry.
Sir, predicted post-operative FEV1 and
Absolutely.
predicted post-operative DLCO values will be calculating through the spirometry.
Okay, so how will we calculate if I were to remove the whole of right lung? So how much do I lose? How much functional capacity do I lose?
Sir, for that predicted post-operative FEV1 value is calculated by the formula pre-operative FEV1 multiplied by 1 minus the percentage of the functional lung removed by 100.
So how much is the functional lung being removed?
So that is the number of the total number of the subsegments removed upon 42, sir. That will give the into 100 will give the percentage.
What is that in this case?
It's at 22 by 42.
So answer वहाँ से शुरू होता है, right? When you know the answer, you said we remove 22 of the functional segments out of 42. So the whole thing, the predicted one will be the initial one minus whatever functional I am removing. उसके लिए वो formula बना दिया है, वो ठीक है. So 22 upon 42, which will be almost a little more than 50% of the जो pre-operative अगर 80% है, तो post-operative 39% FEV1 रह जाएगा. Approximately.
Yes.
You should understand that formula seems very interesting, but I feel it is very silly. You know, if I am removing 21 out of 42, then I am removing half the lung. You know, half the functional lung I am removing. So if the initial FEV1 was 90% of predicted, then later on it will be 45% of predicted. Right? Simple है ना? Formula याद कर लीजिए, लिखा हुआ है, but it is as simple as that. Get my point?
Yes.
Next time पढ़ेगी तो उसको उस तरह से भी देख लेना एक बार. So spirometry is helping me, ABG is helping me, METs are helping me, right? In this patient, what is the METs? METs का form क्या है वैसे?
Metabolic equivalent of task score.
Right. So what is this in this patient?
Sir, my patient can climb 2 flights of stairs, so it is more than 4, sir.
गलत है ना? इस केस में more than 4 is not important. I would need the exact value 6, 7, 8. That will give me a rough value of METs will reflect a rough value of what?
Sir, cardiopulmonary reserve, sir.
In this form, what is the other important invasive test which is done for that? Or not invasive, but much more strenuous.
VO2 max.
Max. So one MET is roughly how much VO2 max? Right? There is a value to that. So each MET is about 3.5
ml per
oxygen
per minute.
नहीं पूरा बोलो, पूरा उसका यूनिट्स बोल.
So 3.5 ml per kg per minute of oxygen consumption.
Okay, per minute, isn't it? So that
Yes.
is VO2 max. So if I knew the exact value of METs to be 6, then I'll also know that it is 21 ml of oxygen per, roughly 21 ml of oxygen per kg per minute, which will be a nice rough surrogate for the actual VO2 max. No?
Yes, sir.
So that means, going back to your history,
Yes,
in
sir.
this case, the history should not say the usual more than 4 METs. It should say that it is 6 max, 6 METs. It seems like it is 6 or 7 METs. No?
Yes, sir.
So if you had given the same point to me in history, I would have been very happier, you know. I'm happy even now, the way you are presenting beautifully, right? So, we are doing the pre-operative investigations. And you have said that the investigations that you want to do are spirometry, AVG, and the CT scan, and you have justified them. Any other? For this patient?
Sir, 2D echocardiography, sir.
Why?
Sir, to know the biventricular function, to rule out pulmonary hypertension, sir.
Okay. But as you, in this patient, he has a nice exercise tolerance, reasonably, and many other things. Yes, it's a procedure which is pretty invasive, and it would be a good idea that we do that. Right. Okay. Anything else?
Sir,
Okay. So let us say that the patient has an FEV1, 90% of or 80% of predicted value. His VO2 max is about 17-18 ml, and his AVGs are acceptable to us, right? So then we stratify this patient as mild to moderate risk. No?
yes, sir.
Now this patient is slated for surgery. What are the pre-operative orders? You will write 50 kg person for pre-operative orders. The patient has been declared fit by you.
Sir, I'll order for smoking cessation, then continue the bronchodilators. Then I'll advise for the N-acetylcysteine nebulization, chest physiotherapy, breathing exercise, recruitment activities like incentive spirometry, debriefing exercises.
So let us do it in two phases. One is that you have got 10 days at your disposal. One is that it is tomorrow, right? I take you to a corporate hospital. You're not going to get these 10 days, right? Which you are thinking कि मेरे पास इतना दिन है कि cigarette cessation हो जाएगा और ये भी हो जाएगा और वो भी हो जाएगा, right? This patient seems to be well preserved, reasonably well preserved. So the surgeon says, I want to operate him day after tomorrow. What are the preoperative orders? You were doing a great job. You were trying to recruit the lung. You were trying to, chest physiotherapy will have very little role in this patient because it is nothing like an abscess or something which you can drain out. It's a tumor which is sitting there, which is blocking and obliterating. So please keep that in mind. Don't give general answers when it becomes a particular patient. So stick to that patient. Get my point? That will enthuse the examiner much more. कि ठीक है इसके दिमाग में वो पेशेंट लगा हुआ है, चिपक गया, right? You get my point? So so if you had said, okay, sir, chest physiotherapy is an option, but I don't think this will help too much in this patient, I'll feel great. Okay, this person has already planned कि ये patient मेरा है, ये वाला, you have owned the patient now. अच्छा, तो अगर 2 दिन के बाद होना है तो
Sir, smoking cessation, continue with the bronchodilators, then N-acetylcysteine in this.
Why are you after N-acetylcysteine? By the way,
He's having cough and mucus production, so I want to get loosen those expectorations. So for that, sir,
no harm.
I would do that.
What else?
Sir, then I'll give the antibiotic.
First three things you have given. Continue this, continue that, do this. 3. 4 is antibiotic.
Antibiotic.
Achha.
Antibiotic
Why?
prophylaxis.
What is that for?
So prophylaxis before a surgery.
Why? You are bothered about infection, or the surgeon is bothered about infection?
Surgeons.
Are you getting into that field which is not yours? दे देगा उसको चाहिए होगा तो तुम क्यों पीछे पड़े हो? Is it affecting your approach? Patient doesn't have any symptoms of infection at the moment. उसके protocol में है देना तो देगा, नहीं होगा तो they will not give. So let us stick to our field further. Okay, next.
Sir, I'll take.
Orders.
Sir, I'll go. I'll say for. I'll educate the patient about the procedure, and I'll discuss with him the post-operative.
The operative orders 1, 2, 3, 4, 5, 6. 5, 4 we have done antibiotic cover. 5th order number 5.
Sir, antacids, I'll say.
Why? What is happening to his acidity?
Sir, because to decrease the chance of aspiration.
Should he aspirate? You are a good person. You will not do. You will do a great job. Why will your patient aspirate? He is not full stomach. He will. The main things, that is my problem. Why I am asking this? I wanted you to begin with consent. You have not talked about consent. Whether it is a high-risk consent or not, I have not heard that. I have not heard whether he'll go to the ICU. There is a likelihood of going into the ICU and a consent to the same effect. Then fasting orders. They should come first and naturally. Then karenge is case ka specific. And unfortunately, the things which are becoming regular are antacids and antibiotic cover. That means you are not happy about your own capability. So I don't see anywhere that these are regular as pre-operative orders. Okay. So carry on. For this patient, anything else?
So these written informed consent, NPO advices for the patient. Then get the blood group cross-matching done. Arrange for the ICU bed and ventilator, and I'll discuss the post-operative analgesia, multimodal post-operative analgesia ways with the patient, and educate him about this, and
You don't
educate
write. I was saying you write in pre-operative orders. You do it. It is part of the pre-operative checkup that you make rapport with the patient, you explain the procedure, and that's very nice of you. But they do not come as, if you want that all these have been done, but they are not pre-operative orders. Do you want to give any sedation?
Sir, I would avoid sedation in this patient.
Why?
Sir, because these respiratory compromise is already there, so I
sleeps very well, doesn't get up at the night, he walks 2 flights of stair. क्या बिगाड़ा उसने आपका? What is wrong? His airway is safe, no finding in the airway. And he has been told that it's a high-risk surgery and he can also go into the ICU. So do you think he will be anxious or not?
He will be, sir.
I don't see any contraindication. You don't want to do it. I don't know why. So anyway, so these are the pre-operative orders, because we have limited time at our disposal. So I'm just making you aware that jo roz karte ho routine, please speak that out. Don't say strange things in the exam. You begin with consent and nil oral, pre-operative anxiolysis, and so on, and then come to a particular case. Now this case needs blood, yes, grouping cross-matching. This needs ICU, yes. Be ready with the high-risk consent and risk consent about that, yes. Okay. So now the patient has been sedated and he slept well, came to the OT. Now, what do you want to, how do you want to induce this patient? His blood pressure on the table is the same as you told me in the pre-operative. 120 by 70 or something. His pulse rate is fine and he's on the table.
Sir, after taking the patient, sir, first I'll prepare my OT.
OT is prepared. Just listen to my question. How do you have put the lines which you love to put, whichever line you want to put. Okay, arterial line, central venous line, every line has been put. Okay, now you are ready to induce this person.
Sir, first I will secure the thoracic epidural and epidural at the level of T7 and T8, and I'll give the test dose, and then I'll make the patient lie down. Then I
will give thoracic in sitting position.
Yes.
Okay. T7-8.
Yes, sir.
Okay, so you will give the test dose.
Yes, sir. Ligno.
Okay. Then
Then I will make the patient lie down, and then I'll start the pre-oxygenation of the patient. By 100% of oxygen.
The question was, what induction agent will you use?
Sir, I'll be using propofol in the titrated doses.
What is titrated doses? I don't understand. He is
Sir,
50
before that,
he is 50 kg.
Sir, I'll be giving 100 mg. Slowly, I'll be giving in the titrated doses, seeing when the verbal response is abolished.
So verbal response abolished at 60 milligram, you will stop there.
Yes, sir.
Do you do that 10 milligram and then you talk to him at what are you,
We ask the patient to count.
So whenever he stops counting, we stop.
So that shows the effect of has come.
And you stop there. Okay, carry on. Then?
Sir, then after.
So you would like to intubate this patient using which, what device?
Sir, I'll intubate the patient with a disposable PVC double lumen tube of Robert Shaw design, left-sided double lumen tube I will use, sir.
And how will you check whether it has gone into the right place or not?
Sir, first by auscultatory method I'll be checking.
Okay.
First I'll inflate that, after inflating the tracheal cuff, I'll check for the bilateral ventilation, and then I'll clamp the tracheal lumen and open the port, tracheal lumen, and then I'll open the port on the distal to it and inflate the endobronchial cuff, and then I'll check for the unilateral ventilation, and then I will unclamp the tracheal lumen. And
you check it fibroscopically.
Sir, I will introduce it through the tracheal lumen first, and then I'll check whether the bronchial lumen is in the correct bronchus by seeing the endobronchial cuff, the blue colored endobronchial cuff, crescent shaped, whether it is correctly placed or not. And then introduce
you
it.
Put a double lumen tube and the surgery is underway. The patient is in lateral position. Lateral position, isn't it?
Yes,
with the right side up.
Yes.
Okay. Now, what do you do to prevent hypoxemia during one lung ventilation? To prevent.
Yes.
You don't want it to happen at all.
Sir, I'll give a PEEP to the dependent lung, and I'll be giving CPAP to the non-dependent lung.
As a precaution?
Sir, I'll keep the MAC less than 1. I'll avoid using nitrous oxide, and before starting, I'll go for a 2-lung ventilation as long as possible. And whenever I'll switching to 1-lung ventilation, I will give 100% oxygen, do the complete denitrogenation for 5 to 6 minutes, and then I'll start for this 1-lung ventilation.
So in 1-lung ventilation, you will use only 100% oxygen.
No, sir, I will maintain my patient on 50% of oxygen, 50% air. I'll use sevoflurane of 2%.
You use less than 1 mag, then the patient will be awake.
No, sir, I'll be using balanced anesthesia. I'll be using IV anesthesia as well.
So that means if you want to use less mag, then you will have to use something to supplement the narcosis, isn't it? If you want to use less than 1 mag, then you will have to supplement it with something. And what is that be?
Sir, propofol or propofol I'll use.
Infusion form?
Sir, I'll supplement in between, sir.
So from time to time. So
Yes,
you'll
sir.
be doing some monitoring which will tell you when to give more propofol.
Sir,
You'll do some monitoring which will tell you that now is the time to give propofol.
sir, end-tidal CO2.
Which mathe pe lagate hain. Something on the forehead. Some electrodes on the forehead can help.
This monitoring.
That will help you if at all you want to give small boluses. Otherwise, and so how will we, what do you plan to do after pneumonectomy? If it was a left-sided pneumonectomy, then what will be the problem? Can we still put a left-sided tube in a left pneumonectomy?
Yes, sir, we can use.
But then they will, when they clamp the bronchus, main bronchus, they will clamp the tube also.
Sir, for that we'll be pulling it back if when they're clamping it.
Okay, so we'll have to pull it back when just before they
Yes.
clamp the main bronchus.
Yes.
And then the post-operative pain, how do you want to take care of?
Sir, I have secured thoracic epidural analgesia, so by that I'll be maintaining the analgesia in the
Only that?
postoperative period.
You said multimodal. I heard something like
It's a multimodal.
And where is the multi?
Yes, sir. So
So
systemic
you-
analgesics, I'll be using systemic analgesics like
Right.
opioids, low dose ketamine, NSAIDs, dexmedetomidine.
This is too many.
And
Which one? Pick one.
sir, I'll be going for the opioids and NSAIDs, and I'll be going for the nerve blocks.
With thoracic, you will give nerve blocks also. So just
Sir,
as I said, own your patient. Own your patient. Whenever you come to the exam, you have owned that patient. Now you have already formed your made up your mind. Thoracic epidural along with blah blah blah. You know, multimodal is that one is at the center, one is at the periphery, and one is at the conduction. So periphery, some COX inhibitor, some kind. Central, some of your opioids, and the passage you have already done. No, that is what is multimodal, isn't it? So anyway, so thank you. I think we are just, you will be happy to know that we have finished this part for the simple reason that Devang has to speak for about 15 minutes. And I'd like to have another 5-6 minutes. So well done, Swati. And I hope that I did not bother you too much. And you could get some hang of how the examination goes. And because we have limited time, so I'll stop here and thank you once again. And I think because Devang is looking after the whole gamut of the things where most of your questions will be answered. Right, Swati?
Yes.
So I'll clap for you. Well done. Thank you. Devang, over to you.
Thank you, sir. Now I will briefly describe the application of the principles of thoracic anesthesia to our case. So there are many types of lung resection surgeries, including wedge resections, segmentectomies, lobectomies, and pneumonectomy. Pneumonectomy involves the resection of the complete lung. And these are associated with very high perioperative mortality rates ranging from 5 to 18%. Various indications of pneumonectomies include bronchial carcinoma, especially when its anatomical location is not amenable to alternative resection, like when it's originating from the mainstem bronchus, it's proximal to the bronchus intermedius, or has hilar involvement. Other indications include traumatic injury to lung with uncontrollable hemorrhage, bronchial obstruction with destroyed lung, chronic lung infections causing extensive parenchymal damage, and certain congenital lung diseases. So for the pre-anesthetic evaluation of a patient posted for pneumonectomy, first we'll start with detailed history regarding patient's quality of life and functional capacity. In our case, which we just discussed, the METs of the patients were more than 4. And although the patient complained of dyspnea, it was mostly associated with coughing. Then we'll take history of 4 M's in the cancer patients. These M's are mass effect, metabolic effect, metastasis, and medications. Our patient gave no such history. Coexisting diseases are also very important in patients posted for pneumonectomy. Since most of these patients are smokers, they are candidates for IHT. But our patient gave no such history. And again, history of smoking, chemotherapy, or radiotherapy becomes important. Our patient was a smoker and was smoking since last 30 years. After evaluating, certain assessment investigations are also indicated, like transthoracic echo, which was essentially normal in our patient, a baseline spirometry, and the 3-legged stool assessment. The 3-legged stool of pre-thoracotomy respiratory assessment includes 3 parameters: the respiratory mechanics, cardiopulmonary reserve, and lung parenchymal function. First, the respiratory mechanics. They may be assessed using various parameters like forced expiratory volume in 1 second, FEV1%, forced vital capacity, maximum voluntary ventilation, residual volume divided by total lung capacity. But the most valid test is the predicted post-operative FEV1% or the PPO FEV1%. It is calculated by multiplying the pre-operative FEV1% by 1 minus % of the functional lung tissue removed divided by 100. Or alternatively, the pre-operative FEV1% multiplied by 1 minus number of lung segments removed by 42. A PPO FEV1% of less than 40% indicates high risk, while less than 30% indicates very high risk for post-operative pulmonary complications. In our patient, the pre-operative FEV1% was 85, and his PPO FEV1% came out to be 40.48%, which was more than 40, and hence our patient was at moderate risk for post-operative pulmonary complications. Next is the cardiopulmonary reserve. And the VO2 max is the most useful predictor for it. VO2 max is the maximal oxygen consumption. A VO2 max of less than 15 ml per kg per minute indicates high risk, while less than 10 ml per kg per minute indicates very high risk for postoperative pulmonary complications. The gold standard for assessing cardiopulmonary reserve and calculating VO2 max is cardiopulmonary exercise testing, CPET. It might employ the use of a treadmill or a cycle ergometer. Other alternatives to this formal laboratory exercise testing include assessment of metabolic equivalence of task or METs. These may be assessed by ability to climb 2 flights of stairs without stopping, which would indicate a MET of more than 4. Then 6-minute walk test might also be employed. It calculates the VO2 max by dividing the distance walked in those 6 minutes divided by 30. And if any time during the 6-minute walk test, the saturation dips by more than 4%, it automatically indicates a high risk for post-operative pulmonary complications. In our patient, he was able to walk 430 meters in this 6-minute walk test. So his VO2 max came out to be 14.33 ml per kg per minute, which indicated high risk for post-operative pulmonary complications. But since the cutoff value was 15, it's almost borderline. Apart from these tests, a shuttle walk test might also be employed, in which patient walks at a fixed and gradually increased rate between 2 markers kept 10 meters apart. If the patient is able to walk a distance of 250 meters, it corresponds to a VO2 max of 10 ml per kg per minute. Next is the lung parenchymal function, which indicates the gaseous exchange between alveoli and pulmonary vascular bed. It may be assessed using a preoperative arterial blood gases, A PaO2 of less than 60 and a PaCO2 of more than 45 mmHg would indicate high risk. In our patient, the PaO2 was 85 mmHg and PaCO2 was 42 mmHg. So he was not categorized as a high-risk patient. Although the most useful test remains predictive post-operative diffusion capacity of carbon monoxide, that is PPO-DLCO%. It is calculated quite similar to how we calculated PPO-FEV1%. So the PPO-DLCO% equals preoperative DLCO% multiplied by. Okay, sir. In our patient, the PPO-DLCO% was calculated using the preoperative DLCO%, which was 84, and it came out to be 40%, indicating a moderate risk for postoperative pulmonary complications. Another important investigation is ventilation perfusion scintigraphy or VQ scanning, which identifies the non or minimally functioning lung tissue. Because all the previous tests which we have undertaken, they assume that both the lungs are functioning equally and optimally, which is not true in the practical sense. So the predictive postoperative functions may be modified accordingly to the results of the VQ scanning. This VQ scanning is indicated in patients who are scheduled for pneumonectomy with preoperative FE1% or DLCO% less than 80%. No, our patient was not. Then factors, there are certain factors which are associated with increased risk of desaturation during OLV. And the history regarding these factors must also be taken in the preoperative period. These factors are if there's a high percentage of ventilation or perfusion to the operative lung on preoperative VQ scanning, if there is poor PaO2 during two-lung ventilation, particularly in the lateral position, if the patient is posted for right-sided thoracotomy, if patient has some pre-existing restrictive lung disease, or if patient is supposed to be in supine position during the one-lung ventilation. In our patient, there was only one positive risk factor, that the patient was scheduled for right-sided thoracotomy. Now, moving on to pre-anesthetic optimization, we asked the patient to discontinue smoking, continue with chest physiotherapy and postural drainage, incentive spirometry, steam inhalation and mucolytics, continuing with the nebulization with bronchodilators, which he was already on, anxiolysis, and optimal NPO duration.
I think we did not need any chest physiotherapy for our patient because
already
basically a cancer. So
yes, sir. The lung functions are optimal in that patient, in our patient. The final pre-anesthetic management included reviewing of the initial assessment and test results, assessing difficulty in lung isolation, and determining the size of DLT by using digital chest X-ray or CT scanning, assessing the risk of hypoxemia during OLV, which we have already discussed, appropriate risk stratification and consents. Our patient was stratified as high risk for postoperative pulmonary complications, and hence a postoperative ventilation and ICU stay consent was taken. And finalizing the anesthesia plan, including the lung isolation techniques to be employed. And it was decided that we would be employing a 39 French sized left-sided DLT. And the postoperative analgesia plan was also discussed with the patient, and we zeroed in upon use of thoracic epidural anesthesia and analgesia. The intraoperative monitoring which we employed in this patient was pulse oximetry, 5-lead ECG, end-tidal capnography, invasive hemodynamic monitoring using a CVP line and invasive arterial line for both IBP and frequent ABGs, ventilation using continuous spirometry as displayed on the anesthesia workstation, temperature monitoring, urine output monitoring. These were the monitorings which we had employed. Apart from it, pulmonary artery pressure monitoring and trans-esophageal echocardiography might also be employed. Our plan of anesthesia was GA with controlled ventilation with maintenance of two-lung ventilation for as long as possible. And we had also planned to put a thoracic epidural T7, T8 level for postoperative analgesia. Anxiolytic agents in the form of tap alprazolam 0.25 mg HS on the night before surgery and injection midazolam 0.05 mg per kg IV before induction were administered. The patient was adequately pre-oxygenated with 100% oxygen for 3 minutes. And IV fentanyl and induction was done using IV propofol. For muscle relaxation, injection vecuronium was used. And as far as inhalational anesthetics are concerned, isoflurane, sevoflurane, or desflurane, any of these can be used preferably at a MAC of 1 or less than that. Because at 1 MAC, these inhalational agents cause 20% inhibition of the HPV, which translates into a 4% increase in the shunt fraction, which hardly leads to any hypoxemia. So the point which we are stressing over here is that use of inhalational agents up till 1 mAh is quite safe. So we decided to use sevoflurane in 50% oxygen in air mixture. And to supplement it, we used IV fentanyl infusion throughout the intraoperative period. Nitrous oxide is avoided in these patients because it leads to a higher incidence of post-thoracotomy atelectasis, increased pulmonary artery pressures in pulmonary hypertension patients, additional inhibition of HPV over and above what inhalation anesthetics are causing, and it is strictly contraindicated in patients with Blebs bullae. The lung isolation was achieved, as we have already stated, using a 39 French left-sided DLT, and its position was confirmed using fiber optic bronchoscopy. And to prevent hypoxemia, a CPAP of 1 to 2 centimeters of water was applied to the non-ventilated lung. Normothermia was ensured throughout the procedure using warm fluids and forced air warmers, and optimal fluid balance was maintained. For maintaining this optimal fluid balance, it was ensured that no fluid was administered for any third space losses during intraoperative period. And fluid therapy was targeting a urine output of around 0.5 ml per kg per hour, and not more than that. And the total positive fluid balance in first 24 hours post-operatively should be less than 20 ml per kg, which translates into crystalloids of less than 3 liters in first 24 hours in an average adult patient. If there is a need to increase tissue perfusion post-operatively, instead of using fluids, inotropes should be used with invasive hemodynamic monitoring. The ventilatory strategy in this patient was to maintain 2-lung ventilation for as long as possible and to use controlled mode. Although either of the control mode could be used, we used pressure control mode because it is preferred for lungs which are at risk of injury. We were targeting a tidal volume 5 to 6 ml per kg ideal body weight, and we kept peak inspiratory pressures and plateau pressures less than 35 mmHg and less than 25 mmHg respectively. A PEEP of 5 to 10 centimeter water was employed. Initially, we had kept a respiratory rate of 12 per minute, but it was adjusted to maintain a PaCO2 of 35 to 40 mmHg. Similarly, FiO2 was also titrated to maintain a saturation of 92 to 98%. Once the surgical procedure was done, there was thorough suctioning was done and recruitment maneuvers was employed to the lung. And extubation protocol was as per the predicted post-operative FE1%. In case PPO FE1% was more than 40%, as it was in our patient, we planned for extubating that patient in the room, provided the patient was alert, warm, and comfortable. The post-operative management in this patient includes post-operative X-ray to rule out any pneumothorax, hemothorax, lobar collapse, or misplaced strain, judicious fluid therapy, as we have already discussed, adequate analgesia, warm and humidified gases, chest physiotherapy and incentive spirometry, and ensuring adequate cuffing response. Post-operative analgesia can be administered in the form of systemic agents or nerve blocks. I think these options have already been discussed by Sir. But in our patient, what we did was we employed the use of continuous LA infusion through thoracic epidural catheter, along with injection paracetamol 15 mg per kg IV. Now, briefly, we'll discuss one lung ventilation, which is the intentional collapse of the lung on the operative side to facilitate thoracic surgical procedures. Collapsed lung continues to be perfused, but is deliberately not ventilated. This leads to creation of a large right to left shunt amounting to 20 to 30% of the cardiac output. And this leads to a wide alveolo-arterial oxygen gradient, which might result in hypoxemia. Although certain factors avoid this, try to prevent this. These are hypoxic pulmonary vasoconstrictions, as well as the surgical compression. Both of these decrease the blood flow to the non-ventilated lung. Elimination of CO2 remains unchanged, provided minute ventilation is unchanged and pre-existing CO2 retention is not present. Hypoxic pulmonary vasoconstriction, or HPV, is the local response of pulmonary artery smooth muscle, which decreases blood flow to the area of the lung with low PaO2. It improves PaO2, or the arterial oxygen tension. The exact mechanism of HPV is not very clear. It might be caused by the hypoxia or the vasoactive substances released by the hypoxia. The HPV aids in keeping a normal VQ relationship by diverting the blood from underventilated to the well-ventilated areas. It's a biphasic response with rapid onset over 30 minutes, and it peaks at around 2 hours. Our aim during one lung ventilation is to maintain HPV by either decreasing or eliminating the factors which inhibit it. The factors which inhibit HPV can be divided into direct and indirect factors. Direct factors are volatile agents, but as we have already discussed, safe to use in MAC up to 1. Vasodilators like nitroglyceride, sodium nitroprusside, and dobutamine. Conditions which increased pulmonary vascular resistance like mitral stenosis, myocardial infarction, and pulmonary embolism, and hypocapnia. While indirect factors which inhibit HPV include a high PEEP, more than 15 centimeter of water, and vasoconstrictor drugs like epinephrine and dopamine. Various intraoperative complications associated with pneumonectomies are hypoxemia, which is by far the most common complication. It leads to an increased intrapulmonary shunt fraction. Then sudden severe hypotension can be seen, sudden changes in ventilating pressure or volume, arrhythmias, bronchospasm, massive hemorrhage, hypothermia, and neurovascular injuries. Now, how to manage an episode of hypoxemia encountered during OLV? One, if that episode is severe or precipitous, then 2-lung ventilation should be resumed if at all possible. If it's a gradual desaturation, first FiO2 should be increased to 1. The position of DLT or blocker is reconfirmed using fiber optic bronchoscopy. Optimal cardiac output is ensured, and the MAC of the volatile anesthetic should be decreased to less than 1. Then recruitment maneuvers can be applied both to the ventilated and the non-ventilated lung. Ventilated lung in the form of a PEEP of 5 centimeter water, and non-ventilated lung in form of CPAP 1 to 2 centimeter water. Then partial ventilation techniques can also be applied to non-ventilated lung, and various pharmacological manipulations can be used. And the last resort, if everything else fails, is probably a veno-venous ECMO. Now, these days, video-assisted thoracoscopic surgeries are becoming increasingly popular for lung resection procedures as well. These are minimally invasive diagnostic and therapeutic techniques. In these, ports are placed in the chest wall, and these are minimally invasive. Okay, sir. And these have various advantages over the traditional open thoracotomies. Over to you, sir.
Thank you very much. वहाँ पे म्यूट कर दीजिए उसको, वॉल्यूम कम.
Sir.
Thank you very much, Devang. Very nicely and beautifully summarized. And I would like to share my screen. Can I share my screen? Right. Okay. There. Where is it? This one?
No, sir. 1 second. It's
okay. So just to summarize today's presentation, very nice presentation by our friend Swati, and beautifully summarized and given the overview of thoracic anesthesia, Dr. Devang. I'm really thankful to Dr. Kaur for giving this opportunity, and to the whole team of APPEC here. They have been doing a commendable job over the last few years, and it has come of age really. And now the hybrid modes and the online modes are really making waves. So, as far as the thoracic anesthesia is concerned, we have had our share of experience with thoracic anesthesia. I've been very lucky that I'm not working in a CTVS center, but still in my lifetime, anesthesia lifetime, about 43 years plus, I would have conducted nearly 50 and supervised another 30, out of which at least 20 were VATS thoracic surgery. And we have been doing these workshops which have taught us a lot. And one of these very sought after workshops has been lung isolation skills, which we are doing year after year with the Airway Management Foundation. And the next one is due on February at Patna this time. And Dr. Kaur, and if you look at this collection of constructors, you can see a number of people who are from this very institution. So we are lucky to have wonderful instructors from all over the country and the world, in fact. And we have had a little bit contribution in thoracic anesthesia in the form of 2 CPAP devices, which are indigenous, and we realized the importance of using CPAP device to the non-ventilated lung. But I would like to put on record here if you want to use a CPAP device, it is better that you do not allow the lung to collapse totally and then apply CPAP device. The CPAP device should be applied right in the beginning when you are opening the lung to the atmosphere. Rather than opening it to the atmosphere, open it to the CPAP device, and then you can adjust the CPAP and really recruit keep the alveoli recruited on the non-ventilated lungs. A little bit of history that we began with bronchial blockers, went on to the endotracheal and bronchial blocker combinations, then the single lumen tubes, and then came the DLTs. And I have had the pleasure of touching and feeling these tubes at my center at Maulana Azad Medical College. These tubes, Dr. Kaur and all seniors will remember these tubes. And this was the first endotracheal tube with a bronchial blocker, which was Macintosh Lauderdale endotracheal tube with a bronchial blocker, which was on the left side. That itself also had a lumen, which allowed us to suction out the non-ventilated lung and also apply CPAP. Although we had not thought of CPAP at that point of time. Then we had the double lumen tube, Carlins and White, which both of them had carinal hook, and white is right. We used to remember like that. And I have used this in a couple of cases. And then, of course, the Bryce-Smith and Bryce-Smith salt right and left tubes were there. I have never used this, but then Robert Shaw took the race from everybody else. And most of the modern day DLTs are based on the Robert Shaw double lumen tubes. And current use, we have these 3 apparatuses that we are using. The double lumen tubes which are available are 35 to 41 sizes. But on the left side, another 2 sizes are available, and I have the opportunity to use a size 28 for a female in our setup. So, and you look at the internal diameter of these tubes of the 2 lumens, that needs to be kept in mind as well. So these are the double lumen tubes. When you use a double lumen tube, you must remember the tracheobronchial tree, which Swati has told us to some extent, but also remember that we have a very little space on the right side before the right upper lobe bronchus is given away. So definitely the right tube placement is a little more tricky, but then it is so much more exciting as well. So I've been using it in cases where it was not exactly needed, but then to remain in touch, do keep on using these in places where you have fibroscopy at your disposal. So how do you choose the appropriate size? As I said, and I told Swati, that although all these things are available, chest radiographs is a very underused technology, because when you look at this chest X-ray, how many of us know that there is a marking on the side which gives us the centimeter line is there in each of the new X-rays, and if you convert this 1 centimeter into how many millimeters, you can find out how much is the trachea. If you measure the trachea at the interclavicular area, and then you can, and as far as the depth of insertion is concerned, although there is a formula, I always use this trick. I place a DLT in the parasagittal plane. I measure the distance from the angle of the mouth to the angle of the mandible, and then to the angle of Louis, and then add another 3 centimeters, and I have a rough estimate of how much tube I have to introduce. And then placement of the lower lumen tube needs preparation to begin with. But all monitors which Devang has told in detail, your fiber scope should be there, the tubes and connections should be nicely checked. You need 2 syringes on your table, on your, lubricated, because it's a large tube going through the vocal cords. The 2 syringes, one for the tracheal cuff, one for the bronchial cuff, they should all be there. So all this preparation is needed before you go on to do. And when you introduce, please notice that there are 2 curvatures in the double lumen tubes. And when you are introducing, the bronchial curvature has to, the concavity has to face forwards. Once you have introduced it into the through the trachea, you have gone through the trachea, that is when you rotate it. once you have passed the vocal cord, you rotate it in such a manner that the bronchial cuff, which is blue, this is blue and this is transparent. Now you get a feeling of a resistance. That is where you stop, and then you can do the checking whether you want to do it clinically by auscultating or by obliterating one of the lumens and checking it, or doing it fibroscopically. You can do it fibroscopically as well. And once you go inside, you will see as Swati had told us, you'll see the blue part of the bronchial cuff next to the carina, and that will tell us that we have gone to the left side. And then we go through you can see the side tube going into the left side. And then when you pass through the bronchial cuff, you see that the tube is now not abetting on the bronchial carinas further. So you need to check that also. Now going through to the bronchial lumen. This is the blue cuff which you can see, that means bronchial cuff. And once we go out of this, we should not be abutting on the next carina. If we are, we'll have to pull the tube out a little, right? So this, and when you are putting the right-sided double lumen tube, as I said, very exciting it is. And you see the right side tube going in onto the right side and the rest of the things. Now, when you go inside, now this is that we have gone through the bronchial lumen now. Once I go through the bronchial lumen, first I must go all the way down and should look at the medial and lateral of the middle lobe, and then pull up the fibroscope in such a manner and twist it to the right side and put the ACL down. That is when you will look at the opening. Some of the tubes has a white line which will lead into the bronchial opening. And from there, you should be able to see the typical 3 openings picture of the upper lobe bronchus. That's a beautiful picture. Once you see it, you love it. And this is the important maneuver that you need to do. You have to twist the fibroscope to the right side and then ACL down. That is when you are able to enter the right main bronchus. This is the univent tube, which I have used a couple of times, which is a combination of endotracheal tube and bronchial blocker. Comes in various sizes, can't use below 10 years of age in a patient. And the beauty of this tube is that in difficult intubation cases, it goes in like a normal endotracheal tube. So if you have a difficult intubation patient, this has an opportunity out there. And then once you are inside, you push the fibroscope to the tip of the univent tube, and from there, under guidance, you can monitor the blocker going into the side which you want to take, and then inflate the cuff. You can see the cuff inflating under vision. So let me show you the case where we were putting it on the right side or on the left side. You can see it going on the left side, and on the right side, on the right side. So it's a beautiful picture which you can see on the fibroscope, and you can ensure by twisting and twirling the stellated bronchial blocker into the appropriate side. And of course, bronchial blockers are there. There is an ANT blocker, which has a hook in which you hook your fibroscope, and then the fibroscope guides it into the appropriate side. And then the Cohen blocker has a rotator which can twist the tip to the right or to the left. And then there is a Coop deck, which again is fingered or the hand twisted stellate which it has. And then finally, if you don't have anything at your disposal, which we used to have 25 years ago, we used Fogarty catheter. And we were all under the impression that Fogarty catheter is too small, too narrow for the bronchi of an adult. But then when we took a closer view of the Fogarty catheter, see, the side-to-side diameter of a Fogarty catheter can be as much as 11 or 12 millimeters, which is good enough for most of the adult bronchi. So we have used quite often the Fogarty catheter as the bronchial blocker. And then finally, the VATS pneumonectomy, as I said, we have done 16 cases for a series that was published by our orthopedician to drain the tubercular abscess. They were using multi-port approach, and in which the insufflation pressure is always kept less than 8, as against 12 to 15 when we are doing pneumoperitoneum. We keep it much lower because it tends to cause tamponade onto the heart as well. So this is a uniport method of pneumonectomy. Naturally, the port has to be large enough to finally bucket the lung and take it out. So it's a tough procedure, and a slightly longish incision is needed. When we are doing multi-port for pneumonectomy, we will have to finally end up making at least one incision this big. So that is what it means. So I think this tends to stop in between. So this is what we did in spine, which was published by our orthopedician along with the general surgeon, and 16 cases we did. And remember, I would like to have all my pneumonectomies in ICU for one day, because I'm not very happy with the post-operative care in a normal post-operative ward. We have to take care of the chest tube also on the first day, and also have to take care of such a big space which has been created by pneumonectomy. So thank you very much for allowing me to share my experience with you. And again, I thank everybody at RML Hospital and Dr. Kaur and her team. Thank you very much. And of course, Devang, thanks for being such a thank you. Thanks a lot.
Thank you so much, sir. It was our pleasure to have you as an external examiner and get enriched from your vast experience. There are no questions as such in the chat box, sir. We once again thank you for taking up this topic and giving us your valuable inputs on this very important topic for a postgraduate exam going student. Thank you, Dr. Deva, for your elaborate presentation. So we'll move on to our next session. And for our next session, I would like to invite Dr. Namita Arora. Ma'am is Professor of Anesthesiology at ABVIMS and Dr. RML Hospital. And ma'am's area of special interest